Everyone. Hi, everyone. My name is Colin Gallagher from the University of Melbourne School of Population and Global Health. My pronouns are he and him. I'm still a bit new to this space, so pardon any missteps or lack of fine-grained knowledge I hope to hear from the wealth of knowledge in this room. But today I'll be giving a talk that takes a little bit more of a bird's eye view at service integration from the level of collaboration between organizations. This is part of a research project that was done in collaboration with the Victorian Collaborative Centre for Mental Health and Wellbeing. So I'd like to just take a moment to say thanks to my collaborators at Melbourne Uni, NEMI, and the Collaborative Centre for their contributions to this work. The big question we're talking about here today is, how does the middle matter for collaboration, or the level of meso level, to use academic terms, of sector level collaboration. So what do we mean by middle level? Well, you might have a good idea, but just to be thorough here, when talking about service integration, as we've done through the morning, it naturally makes a ton of sense to look directly at the delivery of services. This means focusing on what we might call, in an academic sense, the micro level, or looking at the interactions between individuals, whether they're consumers or health professionals or peer workers, or interactions among them. That's kind of the macro level. So obviously we take a look at that. But in this talk, we're trying to tease apart about what's going on at a somewhat higher level, at the meso level or middle level of organizations, alliances, governance, and collaboration. So ultimately, we might think that this is a level of potential intervention where certain levers can exist, where we might have an influence on many such service interactions. So let's take a moment to think about how collaboration might make a difference for consumers and the delivery of services. So this is a bit of a composite case drawn from a few stories that I've had in discussion with service providers. We have our consumer, just name them Peter, who is an adult male living in vulnerable circumstances, who has mental health needs compounded by heavy substance use. He has cognitive difficulties which may or may not be the result of an acquired brain injury. And the caseworkers for this consumer are trying to get him into NDIS. But engaging with other services in the area presents big challenges, as Peter tends to present in an aggressive manner On top of this, he's difficult to contact because of frequent changes to where he lives, and he loses his mobile frequently. For this reason, he's frequently turned away from services. So when we talk about conversations with the different members of Peter's support team, we get different stories. On the good side, we hear the course coordinator maintains a positive rapport and working relationship with Peter. And their view is that the other services in the support network need a fresh approach and may be suffering from burnout. They maintain that their own team is flexible and trusts them to figure out what's best for Peter, allowing them to try out different approaches. But when we turn to the other support workers, we hear a different story. They point out past instances such as threats to staff in terms of why Peter has been turned away. And then they even point out to the fact that trying to navigate some of these eligibility processes is a complicated process in and of itself. On the best of days, it's complicated. Never mind that it gets much harder when someone is losing their phone repeatedly and doesn't show up for appointments. So the story I've heard is that of, in some instances, a 3 strikes and you're out policy, where if you don't show up to 3 appointments, you're struck off. And so this isn't a one-off. Peter isn't a single case. There are many cases with similarities to Peter's, and these issues go well beyond the commitment and skill of individual staff members, naturally. So how can organizations support frontline staff working with many such cases like Peter? So our premise here talking today is how organizations collaborate is likely to influence the ability of support teams to coordinate their actions, to maintain trust and shared norms and a shared culture around person-centered care. It's likely to influence their ability to resolve conflict and disagreement, and their willingness to innovate as a way to solve problems. So the task of tracking collaboration has been the key aim of the Canvas project, which is, again, a project carried out in conjunction with the Victorian Collaborative Centre, where we've conceptualized the Victorian mental health service system as a network of interconnected providers. Canvas, as we've seen today, kind of echoing what we've seen early this morning from earlier work, is that Canvas is based on social network methods, where we're really taking a fine-toothed comb to the idea of relationships and how they link up into wider social webs. And using these tools, we can start to interrogate or examine service systems and think about where systems might lack sufficient connection, resulting in siloed systems, as you see on the left, and how they might be turned into better connected systems where information can flow more freely between sections. And so the broad aims of Canvas are to capture the Victorian mental health system as a network looking at a range of relationship types. We asked providers about information sharing, resource sharing, coordination, collaboration on advocacy initiatives, referral pathways, and desired collaboration. So who do you want to work with more than you do now? And so the aim has been to use these social network methods to look for structures and collaborative processes that kind of tell us something about how the mental health system is working or maybe not working so well. So what should we look for in a service system according to theory and prior work? Well, to oversimplify really broad literature, we can look for a few things. First things we might look for is densely overlapping connections, so dense interconnections among our providers. So not just one-to-one connections, but three-way, four-way, five-way connections where many service providers are getting together to do their work. These are the kinds of structures where we can start to think about norms, shared culture, and trust taking root. Centralization is also considered a hallmark of well-functioning service systems, where you have central hubs that can ensure continuity of services for consumers. The literature also points to the presence of leaders, or at least coordinators or administrators within these systems that can do the job of making sure that the different partners are well coordinated in terms of their collaboration. And then finally, we want to make sure that there's enough services out there, that there's a wide diversity of services that can cater to the broad needs, the broad holistic needs of individual consumers, and that there's enough of them, but obviously not too many, or too many that makes it difficult to coordinate, or that there's redundancy and competition. So in the Canvas project, it was a pilot project looking at two regions, the Western Metro of Melbourne, as well as the Hume region of Northeast Victoria. We surveyed quite deeply within several organizations. We ended up getting multi-level data from 16 organizations, but that also included another 25 teams and departments sitting underneath those organizations. These encompass various types of entities, ranging from area mental health to NGOs of various stripes, including providers of local mental health services, other AOD providers, population or community-specific providers. So all of them were focused on adult and older adult mental health and AOD, I should say. One of the hallmarks of the study was our ability to bring this together into a flexible system that allows us to quickly and dynamically collect and report this data. So that was a cool part of the project, but I'll skip over that for now. Here we'll just have a nice little visualization of the data. We have our kind of core of network data that we selected from the organizations themselves, but we see where that expands. So in the first frame, as it's showing, we see the connections between the organizations who participated, expanded into all the services that they mentioned, and then the final frame is even adding the multi-layer aspect onto it. And so having not only lead organizations, but the teams that sit within those organizations represented kind of as, again, a multi-level structure. And making sense of this data, it doesn't rely on just looking at those kind of cool pictures. We have analysis methods, statistical and mathematical methods for just thinking what are the kind of prevalent patterns in the data, what's popping up statistically, and what's relevant in more than just kind of looking at the data. So, what were our preliminary findings from our network? First, we found that providers of local mental health and well-being services are indeed central to the system. Remember, we talked about centrality, but there are some notable gaps. So this is a simplified network diagram of the desired collaboration network. So this was asking, who do you want to work with? Who do you want to work with more than your current working with? And what we see is providers of local mental health services in the lower left-hand corner. In case it's not obvious from the drawing, they are in a central position. This was confirmed kind of statistically. So that's who people want to work with. If we shift over to actual collaboration, so who are you actually working with currently to deliver services, or who are you sharing resources as well? We see where local NGOs are still central in the network, but we see some gaps emerge. So you see a little bit more connection here, a little bit less connection there. So in sum here, we can say that many providers already collaborate with locals, but even more want to work with locals, especially in light of their newness and the shift from the Medicare locums. The remaining gaps seem to be specifically with AOD-specific organizations, as well as population-focused organizations, so organizations focused on particular priority groups. And these results were confirmed through statistical modeling that I won't get into, unless you want to hear. The next finding is that collaboration is one-on-one. It's not alliance-based. So in our sample, we found plenty of mutually affirmed relationships. So relationships where both organizations were saying, this is a collaboration. And that's great. That's a sign of a strong, prevalent collaboration. But what we didn't see was those links adding up to clusters, adding up to multi 3, 4, 5, 6-way clusters of organizations who are all working together. And this gets back to what we might want to see in terms of structures that can build shared norms, shared culture, and build up trust. But in this next one, I slotted this in the break, kind of trying to think about the previous discussion. One more specific thing we might think about in terms of these clusters is that what do these networks mean? So I was speaking with some service navigation teams about the idea of networks, and they questioned what these actually meant. So they said, are these networks of fit for the consumers? Are these like a consumer in one node should go to this next node because that's the best fit? Or are they following that link because that's what's available? So are these networks of fit, or are they networks of availability? And they thought it was more like networks of availability. So consumers are going from A to B because that's the service that's available, not because that's the best fit. So in light of that maybe consumers are maybe getting parked in an available service because they have a timely need, we need to think about, don't we need more clusters in our network where maybe it's the available service and the ideal service and the referring service are all linked up together, but we don't necessarily see that. We can return to that if you don't kind of capture that. Moving on in terms of sector leadership, specifically with respect to living and lived experience. In our survey, we did ask about living and lived experience practices at an organizational level, such as were there designated roles at various levels of the organization, were there KPIs and other organizational goals related to the peer workforce, and was there training of non-designated staff with regards to designated roles. What we found is that the organizations who talked the talk walked the walk. So those organizations who were adopting peer workforce reforms were highly active in the advocacy space. And because they were so active, they were linked up together. So you might think who this would be, but given their activity, they're prevalent, they're central in the advocacy space in particular, and they're linked up into what you might term maybe a reform backbone. But what this didn't extend to was necessarily everyday routine service delivery. So while these kind of while you could call the advocacy network kind of led by these cutting-edge organizations, what we did find in the service delivery network was you have organizations with different approaches to the peer workforce working together. So this does raise issues of one thing we might discuss is whether training on designated roles is something the organization should do, or should it be something that's more widely, it's a sector-based activity, because we have organizations that aren't necessarily doing much with respect to training, coming into contact with plenty of peer workforces. So to sum up here, what have we initially found? Well, we have low evidence of this kind of idea of dense interconnections. Again, so we're seeing more one-to-one interactions, not necessarily clustered interactions, which connote this density. On the upside, we do have some evidence for centralization around local mental health services, although there are gaps left to fill. In terms of there being leadership in the sector, we do see some evidence specifically around living and lived experience reform. But naturally, there's still a ton left to take a look into, such as, is the mental health and well-being sector really linking into a diversity of services that allow providers to link the consumer into a system that will holistically address a wide range of their well-being needs. So thank you. Like to take a moment to thank the Collaborative Center for proposing this work and supporting my work. I think it goes on hiatus now in the current landscape, but happy to chat with anyone who wants to chat further about it. Thank you.
So I'm Sophie. I have met at least half the room at some point in my career. And as the Chief Psychiatrist, I think I do have a sort of sanctioned leadership role in this, and a self-appointed one, to do some of the connection between the things we're talking about today and the tertiary mental health system. And I'm a bit disturbed by the Queen Bee reference, Colin, but if that helps. You know, having worked in Headspace for 10 years and sort of being immersed in some of the things that we're talking about today, and seeing the huge disconnect from the way the tertiary services think and do this work, I think that we, you know, in some ways, I at least need to reflect on how we can bring some of the ways that you're thinking so that those connections can be different. And we do, those of us in the tertiary service, we work in an underfunded system where all those rigid rules, the diagnostic groupings, they're not really meaningful. They're there to limit that feeling of uncertainty and that feeling of lack of control in a very overwhelmed system that hasn't been incentivised or resourced to meet the needs of all the humans in it, let alone the humans seeking help from it. So I feel like there's a huge bit of work we need to do to get these conversations from this group of people. You're all on board, right? Including myself and Sophie Davison, where we were talking in the break. This is sort of preachy to those of us who shares a lot of the same views, and get this connection piece into the rest of the system. And so I guess I take away from all the conversations we have had today, you know, what more can I be doing, but also what more can we be doing? And I guess I'm challenging you because it's really easy to see the tertiary system as bad or reductionistic or clinical, the medical model, all of which terms I'd argue with, because it is made of the same group of decent humans who are wanting to do good things, but it is very stymied by its imagination. And its imagination has been very limited by, for many of us, 30 years working in a really restricted, underfunded world. I don't know how we do it, but we need to get these conversations into that other space. Thank you for your thoughts, Colin, and your work. It's really important.